here. I want to stay on time. Obviously, we're in the GERD pathophysiology and diagnostics session, and the lineup of speakers we have are really top line. Marcelo Vela, who will be giving us our first talk, many of you obviously know. He's a professor at Mayo Scottsdale and really has been a pioneer in reflux testing. In particular, many of the early papers on pH impedance and its predictive value were done by Marcelo and the team with Don Castell, who we all miss and love. So without further delay, Marcelo Vela.
Thank you, John, and thank you to the AFS for inviting me and for putting this great course. I've already learned a lot in the last couple of days. So I've been asked to speak to you about the value of reflux monitoring on and off acid suppression. This is a question that comes up, in clinical practice pretty often. Do you take the patient off? Do you study them on? What technique do you use? So ambulatory reflux monitoring is often used when symptoms and endoscopy are not sufficient to make a clear diagnosis or treatment decisions. So when the diagnosis is not clear, it's also important for preoperative evaluation prior to anti-reflux surgery to explore the role or potential role of reflux in extraesophageal manifestations, to evaluate for belching, which is a tricky thing to look at in clinic, and also importantly in the workup of patients who have an incomplete response to acid suppression with PPIs. So these are the tools that are very well known to everyone here, pH metry, either catheter-based or wireless. And this, of course, allows you to detect acid reflux, come up with acid exposure times, and also look for an association between acid reflux episodes and symptoms. The other approach is to use pH impedance monitoring, a catheter-based approach that measures not only acid exposure, but also the number of reflux episodes, whether they're acid or non-acidic or weakly acidic. Also look for an association between reflux episodes and symptoms. And there are some novel parameters derived from the pH impedance study, and we'll explore some of that also. Now, the usefulness of pH monitoring has been well established for many years right now, and these are very old studies, as you know. But just very briefly, and to remind you, we know that off of PPI, an abnormal pH test predicts the successful outcome of fundoplication, for instance, which is the sort of the most drastic intervention for reflux. Also, patients who have a normal pre-op pH score do not do well with fundoplication because they don't have the problem. Now, performing a pH test on PPI is very low yield, really not recommended. It's a waste of time and a waste of resources. We know that the likelihood of an abnormal test with pH only on PPI is exceedingly low for typical symptoms and even lower for atypical presentations. Again, we've known all of this for a long time. The more maybe difficult questions are related to the usefulness of pH impedance monitoring. Now, the advantage of this is that it detects not only acid reflux, but also pH reflux episodes with a pH above 4. Weakly acidic or non-acidic reflux. And this form of reflux is relevant because it can cause symptoms that are the same as those produced by acid. It can cause heartburn, chest pain, regurgitation. And it is the predominant form of reflux that you'll see in a patient that is taking a PPI, because PPIs generally work fairly well at suppressing gastric acid. It is also treatable, usually by modification of the anti-reflux barrier with a procedure. There are some pharmacological approaches, but there are some problems with that. But one of the weaknesses and one of the pressing questions for a long while now has been, what are the parameters from the pH impedance test that actually predict response to treatment? And we'll get to that in just a minute, but important to note that if you're going to do reflux monitoring on PPI, you should use pH impedance so that you can account for the weakly acidic or non-acid reflux episodes. And this, in fact, has for a while now been defined as a quality measure in the care of patients with reflux. If you're going to test on PPI, don't use pH alone, use pH impedance. So about this sort of weakness of pH impedance, what are the parameters that predict response to treatment? Over the last couple of years, we've had some, I think, very encouraging results that I'll share with you briefly. They're only 15 minutes, so we'll go through this sort of quickly. But I think everyone here is aware of the multi-center randomized control trial comparing magnetic sphincter augmentation versus PPI for refractory regurgitation. You're using LINX versus PPI in 152 patients. that had ongoing moderate to severe regurgitation despite once daily PPI. All of these patients had proven reflux by pH testing off with PPI. They were randomly assigned to the magnetic sphincter or to increasing the PPI to twice daily. And in the context of regurgitation, the magnetic sphincter was clearly superior for resolution of regurgitation. Now, these patients also had pH impedance monitoring, following treatment, and patients in the twice daily PPI arm were allowed to cross over to the magnetic sphincter at the end of the trial. So we had a fairly rich database of pH impedance studies before and after treatment on these patients, and we conducted a post hoc analysis of these pH impedance studies and found that if on BID PPI there were more than 80 episodes by pH impedance prior to treatment, that predicted satisfaction with the anti-reflux procedure. And furthermore, reduction in the number of reflux episodes after treatment to less than 35 was associated strongly with symptomatic improvement. More recently, there was a multi-center international effort to look into this question in greater depth, and there were several groups that were involved in this, and we were able to come up with 66 healthy volunteers tested on BID PPI, and then a European patient cohort that presented with heartburn as the main symptom, and then the North American cohort, from the study I just showed, from the magnetic sphincter augmentation trial, that were regurgitation predominant. So using the pH impedance monitoring on twice daily PPI in these patients and through careful analysis, well, first we define median values in healthy volunteers. Those are not as important for what we're discussing right now. But what was, I think, useful and important is that using a cutoff of on BID PPI greater than 0.5% acid exposure time and or more than 40 reflux episodes, there was good sensitivity for association with symptoms, but more importantly, this associated with improvement following surgical management in about 80% of the patients, more so for those with regurgitation. If you make the definition of abnormal reflux on BID PPI even more stringent, acid exposure time of 4 reflux episodes greater than 80, and then incorporating this new metric, the mean nocturnal baseline impedance, you can see improvement with surgical management overall in 85%. And so I think these two last studies in the last couple of years really add fuel to the notion that pH impedance has value to perform well on PPI therapy, has a value to identify patients that merit an escalation of reflux management with anti-reflux procedures. There are some novel parameters, the post-swallow peristaltic wave index, which is a means of assessing clearance mechanisms, the baseline impedance, which enables evaluation of mucosal integrity in a way, and supragastric belching, which can detect this behavioral disorder. I know Prakash is going to speak about the post-swallow peristaltic wave index and baseline impedance, so I'll just show you one slide about supragastric belching, because this is one of the other, I think, useful aspects of pH impedance, these patients with ongoing belching. Just as a reminder, there are really two types of belching. A gastric belch is really air that comes from the stomach across the lower esophageal sphincter into the esophagus and then out the mouth. As you know, impedance increases when there is presence of air. So you can see in this example there are air increases beginning in the distal esophagus and moving upwards into the proximal esophagus and the throat. In contrast, during supragastric belching above the stomach, what happens is that the patient develops this habit of swallowing air very quickly and then ejecting it. And this leads to this continuous belching. As you can see in this example on the right, you can see the air increases begin in the proximal esophagus, move downward, and then sort of bounce, in the LES, if you will, and come right back out. And some of the patients that are PPI refractory with belching have this phenomenon, and it's important to identify it because they respond to interventions such as cognitive behavioral therapy or, special sessions with a trained speech pathologist. The last thing I wanted to talk to you about in the context of reflux monitoring on and off PPI is the important question of evaluation of symptoms that persist, despite PPI. Of course, we always recommend optimizing the PPI dosing, looking for other etiologies through endoscopy and the help of our ENT, pulmonary, and allergy colleagues. But if you've reached the stage where you need to perform reflux monitoring, you have to ask these questions. Is reflux confirmed or unconfirmed? Are you going to use wireless pH or a pH impedance? Should you test the patient on or off PPI? And these are the recommendations from the International GERD Consensus Group, from a few years ago. And the recommendations are that if you are in front of a patient with unproven, reflux, they've never had erosive esophagitis or a positive pH test, then you should perform a study off of medication and first answer the question, do they really have reflux or not? And for this, you can really use anything. pH is all you need. You're really looking for abnormal acid exposure. You can use pH impedance, but a patient who is not on medication should be refluxing acid for the most part, except in these belching examples. So do the study off of PPI, and of course, if this is positive and it shows an abnormal reflux burden, then you'll have to continue to deal with how to manage their reflux and their unresponsive symptoms. If the study is normal, but there's a strong association with reflux episodes, you'll have to consider treating for reflux hypersensitivity. And if the study is normal and negative, you basically have ruled out reflux, and here you have to consider functional presentations such as functional heartburn or functional chest pain, or an alternate diagnosis, often a behavioral issue like rumination or supragastric belching. On the other hand, in a patient with proven reflux, prior positive pH monitoring or erosive esophagitis, LA grade B or greater, you already know this patient has reflux and you're trying to figure out why are they not responding to the symptoms. If you test them off PPI, it's going to be positive and you already knew that. So test them on PPI to try to figure out what the mechanism of the ongoing symptoms is. If this shows an abnormal reflux burden, there you have proof of persistent reflux. And this indicates the need for escalating therapy. Just as I showed you in those couple of studies, you can use some of the impedance metrics to figure out who will improve with an intervention such as fundoplication. Now, it may be that a patient with proven reflux has only a symptom association suggesting reflux hypersensitivity, but with a normal reflux burden or a negative study. And this means that there's an overlap with functional disorders or hypersensitivity. Just as a patient with Crohn's disease may have an overlap with IBS, a patient with proven reflux can have an overlap, with functional heartburn or some other functional or behavioral issue. And so testing helps you delineate that, and you have to do it because if you don't account for all of these factors and manage them, you won't be able to get the patient all the way better. So in summary, a pH test, whether you use a catheter, as in the old-fashioned days, or a wireless, more common approach now, you should do this off of PPI. Using pH by itself on PPI is a waste of resources and a waste of time. This is the best means to confirm or rule out reflux, which is very useful in clinical practice. It's also useful as part of the preoperative evaluation before anti-reflux surgical procedures. And it's useful to clarify whether reflux is present in extraesophageal presentations and to confirm whether reflux is even there in these patients that do not respond to PPI. pH impedance monitoring is useful in patients that have confirmed reflux and ongoing symptoms, and it helps you answer the question about a potential mechanism underlying this ongoing symptoms despite acid suppression. So use this to test on PPI, looking not only for acid reflux, but also enabling you to account for weakly acidic or non-acid reflux, and the results guide therapy. It can also help you identify supragastric belching in this subgroup of belching patients, and that's important because if you find this, there are useful interventions like cognitive behavioral therapy. And then there are the novel parameters that are being studied, like the PSPW index and the baseline impedance, but you'll be hearing about those in just a moment from Prakash. Thank you very much.
Well, thank you, Marcelo. Excellent talk. I have the distinct pleasure of introducing the next two gastroenterologists, And my partner, Dr. Christy Dunst, will introduce our final surgical talk and also lead the discussion. So without further delay, I'm going to bring Prakash Gowali up to the stage. I think many of you know Prakash with his major work and impact in high-resolution manometry, but today he's going to talk to us a little bit about innovations beyond pH testing in GERD.
Thank you, John.
Walking slow.
And after you've heard all about pH, let's move beyond pH monitoring, talk a little bit about some of the innovations, newer options to adjudicate the situation when pH monitoring alone is not enough. And I'm going to talk about these three entities. You already heard a little bit about baseline impedance. And so this is the impedance signature of a bolus passing across a pair of sensors. And what we mean by baseline impedance is the value, the impedance, the absolute impedance value, when there is nothing happening in the esophagus. There is no bolus, bolus has moved through, there are no artifacts. And this is thought to be a marker of longitudinal injury, in other words, integrity of the mucosa. And indeed, the absolute value does segregate pathological from physiological reflux, and both these groups from healthy controls without reflux. And there is an inverse relationship between the baseline impedance value and acid exposure time, as can be seen here. So how do you calculate this? This was pioneered by the Italians about a decade ago as mean nocturnal baseline impedance. Why nocturnal? Because you don't have any artifacts during that time to confound the value. So 3 10-minute periods between 1 a.m. and 3 a.m., the values are averaged, and you get the mean nocturnal baseline impedance. So this can be measured both at the low sensor and the one above. It is possible that the 5-centimeter value is more representative, although the 3-centimeter value is also utilized. So here's an example. This is one of those 3 10-minute periods. You can see the low values, the normal values in patient without GERD and low values in patient with GERD. There is a simpler way of calculating this. You can take the entire recumbent period and average the value, and that seems to correlate very well with the mean nocturnal baseline impedance measured in this fashion. So when you use mean nocturnal baseline impedance in GERD diagnosis, one of the thresholds that was proposed by the Italians is 2292 ohms. But after studying numerous healthy volunteers, it seems a lower threshold needs to be utilized, somewhere in the range of 1500 to 1700 ohms as a segregator of abnormal values. So values below that level is abnormal. So how would you use it? So physiologic versus pathologic acid exposure time, it's the borderline group where if you have borderline acid exposure time and concordant low impedance values, that might sway your clinical impression towards rather than away from GERD. Indeed, we have demonstrated that in this borderline cohort, the patients with low baseline impedance behave like the patients with elevated acid exposure time in their outcome from anti-reflux treatments. On the other hand, the patients with normal mucosal impedance with borderline acid exposure time behave like patients without pathologic GERD. Now, you can get baseline impedance from high-resolution impedance manometry if the value is taken before water swallows in the baseline or the landmark period. And when you look at the line tracing of impedance, that baseline value in the black box is able to segregate controls from GERD for patients with pathologic GERD as determined by acid exposure time. And this is data from Dave Katzka's group at the Mayo Clinic. And again, there is a negative relationship between the baseline impedance calculated from high-resolution manometry and acid exposure time. Now, one would argue that this baseline impedance acquired from high-resolution impedance manometry might be impacted by fluid in the esophagus. And there is a way of getting around it by measuring the impedance during a contraction sequence, contractile segment impedance. And there have been a few studies looking at this. I will point out one study that was presented at Virtual DDW this year, 40 patients. You can see the breakdown here between heartburn and regurgitation. All patients were studied with high-resolution impedance monitoring and pH impedance monitoring of PPI. And when the contractile segment impedance was more than 500 ohms, only 4% had acid exposure time more than 4, suggesting that this baseline impedance during the contraction segment being above a certain threshold would preclude or would obviate the need for pH monitoring in that the acid burden was going to be normal. So contraction segment impedance, an option for the future. So the summary on baseline impedance, easy to calculate, inversely correlates with acid exposure time, predicts outcome, may be useful when acid exposure time is inconclusive. It is influenced by fluid in the esophagus, obviously, other inflammation, a dilated esophagus where there may not be good contact between the electrodes and the mucosa, and artifact. Watch out for the man in the purple jacket coming after me. He's going to talk more about baseline impedance. Watch this space because there may be more coming in the future about baseline impedance. Next, let's talk about clearance mechanisms. This is a reflux episode in pH impedance monitoring. There is initial volume clearance, usually secondary peristalsis, sometimes primary peristalsis. But within a period of time, some patients and some reflux episodes are followed by a primary swallow that brings saliva to the distal esophagus to clear mucosal acidification. And you can see the pH at the bottom, the red line at the bottom, improve with this PSPW, post-reflux swallow-induced peristaltic wave. You can actually calculate an index, the proportion of reflux episodes followed by a post-reflux swallow-induced peristaltic wave. That's called the PSPW index. And healthy volunteers, at least in the Italian group's hands, had about a 60% incidence of this PSPW. The PSPW index can phenotype reflux into these different categories, refractory reflux having a very low rate of PSPW index. And PSPW index is influenced by esophageal motor pattern, as you can see here, and correlates with acid burden, total acid burden, supine acid burden, and upright acid burden. So there are relationships between the PSPW index and motor function as well as acid burden. Now, what triggers PSPW? And this was studied by Daniel Sifrin's group. The nadir pH and the actual value of the pH does not seem to define the PSPW, but acid reflux episodes, mixed reflux episodes, episodes with high proximal extent, and episodes during the awake state seem to be the ones that provoke a post-reflux swallow-induced peristaltic wave. But as you might imagine, definition of reflux episodes here is critical because if you overcount reflux episodes or undercount reflux episodes, then your PSPW index value is not going to be accurate. So the Wingate consensus, a group of us that got together at the Wingate in London several years ago, looked at this in great detail and determined that the first step in defining a reflux episodes has to be identification of meals and exclusion of meals because meal periods have lots of swallows that might confound the calculation of PSPW and reflux episodes during the meals. So meals can be identified by a very low baseline impedance in the distalmost channel and a repetitive swallow pattern, and these need to be excluded whether or not the patient has identified these. And then the other criteria for reflux episodes, 50% retrograde impedance drop in the distalmost channels that last more than 4 seconds. If there is a pH drop with a belch episode, in addition to the impedance drop, that is also counted as a reflux episode. If there is a pH drop without a reflux seen on the impedance channels, that's counted towards acid exposure time, but not as a reflux episode. And the last statement here is very important. Automated analysis is not reliable by itself and needs manual confirmation or deletion. So leading on to PSPW identification, has to happen within 30 seconds after impedance normalizes. It has to be a swallow with antegrade progression, the proximal distalmost channels with impedance drop of at least 50%. Recovery of pH is not mandatory but helps, and PSPW is best evaluated using a 2-minute window. I'm sorry, my slides seem to have been a little messed up here, but if you focus on the green boxes here, the difference between pre-Wingate and post-Wingate consensus, you can see that the automated analysis overcounted reflux episodes, and the reflux episodes, the number counted decreased significantly when the consensus guidelines were applied. This was true for PSPW as well, implicating that good analysis, careful analysis is imperative. Even in patients with reflux disease, the number of reflux episodes were deleted. Several were deleted with a reduced number of reflux episodes after applying Wingate criteria, and you can see the PSPW numbers in patients with reflux. The problem with PSPW index is that even though it assesses chemical clearance and is triggered by reflux, inversely correlates with acid exposure time, the problem is it requires careful interpretation, and there is a reviewer impression or opinion that goes into this analysis. It is affected by reflux episodes, obviously, but may be affected by whether the patient makes saliva or not. So xerostomia, patients with xerostomia may have a smaller number of PSPW, and the motor pattern also influences esophageal clearance. So this entity may need a little bit further investigation before it's ready for independent use, so it's an adjunctive category. Now, finally, I'm going to talk about high-resolution manometry of motor function. You need contractile pressure, intrabolus pressure, and a gradient across the, or lack of a gradient across the esophagogastric junction for bolus transit. And we measure residual pressure at the EGJ using a metric known as integrated relaxation pressure. So in GERD, with manometry, you want to exclude this condition, achalasia, and you can see the proportion in a large series that had achalasia in the context of referral for anti-reflux surgery. You also want to identify this pattern, absent contractility, and this pattern, outflow obstruction, because this is a heterogeneous condition that can be artifact in some cases, it can be something structural in others, but you have to identify the proportion with EGJ outflow obstruction that might represent true achalasia. Now, there is also the use of provocative testing during manometry that can help further assess patients with hypomodal conditions. We use multiple rapid swallows for this. When repetitive swallows are given, there is inhibition of contraction, but after the final swallow of the sequence, there is an augmented contraction sequence in the normal setting where the mean contraction vigor after the multiple rapid swallows, the contraction vigor after the multiple swallows is greater than the mean contraction vigor from the single swallows, and there is no contraction during multiple rapid swallows. So how can you use this? If somebody has weak or failed swallows, you can see bolus retention in the esophagus, but when you challenge the esophagus in this fashion, those that have contraction reserve are able to clear that bolus, as you can see in this particular patient. And when we studied this in the context of patients being referred for anti-reflux surgery, the absent contraction vigor category was an independent predictor for late post-fundoplication dysphagia. You can see on univariate analysis, pre-fundoplication dysphagia, early post-fundoplication dysphagia, and dysmotility recurrent hernia and barium swallow were all predictors, but absent contraction vigor, at least in this study, was the only independent predictor. So high-resolution manometry in this context rules out motor disorders and assesses esophageal physiologic performance. Now, manometry can also help identify barrier function at the esophagogastric junction. You can look at the tone of the EGJ as well as the morphology of the EGJ, and you can see here that reflux burden is more likely abnormal with the more abnormal morphology at the esophagogastric junction, the type 2 and type 3 morphology that represents hiatus hernia. Indeed, the proportion of patients with reflux that have hiatus hernias is higher than healthy controls, and manometry does seem to be rather sensitive and specific in identifying hiatus hernias in this context. So high-resolution manometry complements EGD and barium studies in increasing yield of identifying reflux burden. Now, this is a maneuver that can be performed during high-resolution manometry. We've been studying this for a little while. Straight leg raise, which increases intra-abdominal pressure. You can see that when the EGJ is intact, there isn't transmission of intra-abdominal pressure into the thoracic cavity. In the patient with type 3 or disrupted EGJ, you can see pressure in the esophageal compartment when the patient raises their leg. Here's another example. And this seems to define a tendency for transmission of intra-abdominal content to the intrathoracic cavity. We looked at pH metrics in the context of straight leg raise and determined that when intra-abdominal pressure transmitted to the intrathoracic cavity, where the intrathoracic increase in pressure, the gradient between baseline and straight leg raise within the intrathoracic cavity was more than 100%. The likelihood of abnormal acid burden was higher, especially in type 1 and type 3 EGJ morphology. Now, manometry can also identify other mimickers of esophageal symptoms. This is a transient lower esophageal sphincter relaxation in a postprandial study, most common mechanism of reflux disease. But you can also identify these behavioral patterns. This is the R wave of rumination. You can see when you add impedance that you see gastric content move up into the esophagus and beyond, rumination syndrome. Here's supragastric belching on high-resolution manometry, a vigorous diaphragmatic contraction that sucks air into the esophagus, and the patient belches that out. These mimickers of reflux symptoms, especially regurgitation and belching, can be seen to a higher degree in PPI non-responders, suggesting that there may be an overlap behavioral syndrome in these patients. So Marcelo mentioned identifying supragastric belching and rumination from pH impedance study. Indeed, the inter-rater agreement is higher with pH impedance testing. This was a study that used 3 raters in multiple studies, but the diagnostic yield may be high if postprandial monitoring is utilized with pH impedance, with high-resolution manometry in the right context, especially if the clinical context is also factored into the analysis. So pH impedance monitoring can be used for investigation of excessive belching, but postprandial high-resolution manometry can also be used in this context. And so in the clinical management, GERD mimickers may not be often identified, and it's important to at least remember to think about these conditions, because management here is behavioral and not invasive. So to summarize, manometry rules out achalasia, assesses peristaltic performance, and identifies mimickers of reflux, but it may be influenced by EGJ morphology and tone, the quality of the study, quality of interpretation, and whether or not provocative maneuvers have been used. Thank you very much. Who's there?
So it's my pleasure to bring up Mike Vasey. I don't know if he's here or back here. You can't miss him. He's got his purple jacket on. It was so hot up here yesterday with all the lights, I figured I wouldn't wear a jacket, and I was going to make fun of Mike's jacket. As you'll see, Elvis has entered the building. So for those of you who don't know Mike, which I doubt that's not an issue for anybody, Mike is probably one of the biggest names in gastroesophageal reflux disease. He's really been a pioneer in new technologies, has focused on a lot of novel and innovative concepts, and is here today to talk to us about a new technology that Vanderbilt and Mike are bringing to the table, mucosal integrity.
Thank you, John. Thank you so much. Sorry, guys. I thought the steps were right here. I had to go in the back. Thank you. Sorry to make you say all that stuff for me to cover the time it took to get up here. But isn't it wonderful to be here? First of all, welcome to Nash Vegas. If you have not gone to downtown Nashville, you should definitely go, because you don't have to pay to just participate in this amazing city. So you will really love it if you go. There are all these party buses, and it will be entertaining. So thank you. This is wonderful to be here. I'm going to talk about mucosal integrity testing. And I'm going to leave disclosures and conflicts on for a while for you to read because normally we just go right through them. This one is important because, as John said, my main conflict, because I'm talking about mucosal integrity testing, Vanderbilt co-owns the patent on that, so there's an inherent bias. I hope my talk won't be, but there is a bias. All right. So, PPI trial, that's what we do for reflux disease. When you have a patient that has heartburn, regurgitation, you start a PPI. We don't do diagnostic testing up front because that's not recommended based on guidelines. You start once a day, then you start tapering to H2 receptor antagonists and to other things. So there was every time I give lectures, I have dysphonia, and Peter Bolofsky was here earlier, and Peter, it's good to see you in Nashville. I get this LPR, I have reflux for whatever reason. So I get reflux, I get dysphonia. But the point that I'm making here is taper the medications when you start PPIs. And he's right in that we have too many people on PPIs at too high a dose. Taper them once you have your answer. So diagnostically, what we do for our patients that have reflux or we suspect they may have reflux is we do all these tests that I'm going to show you, and then I'll put the MI technology in perspective of that. So we usually do that when they have incomplete or lack of response to therapy, which is most of the patients I see. Patients are referred to me because we thought it was reflux. They're not getting better. Why? They're on once a day plus H2, twice a day plus H2 plus coating agents, and you name it. So why is that? So we typically take them off therapy and do the test, or we do them on therapy as Marcelo nicely outlined. Or prior to anti-reflux intervention, because we know that we got to do physiologic tests before we intervene surgically or with advanced endoscopic techniques. So I say come and get it because there's complexity of a lot of the stuff we currently do. I won't get into all of that. That complexity leads to confusion. So if you're confused about what to do for your patients, it's our fault. Because that complexity is, what is reflux? One of the years, I won't tell you who I called, but I called some of the experts. I said, what is GERD, right? As simple as it sounds, is it a symptom? Is it physiologic testing? Which physiologic testing? What's the parameter? And that's what I want to highlight to you. So test, test, and test again. So this I borrowed from Dan Patel. I stole this slide because I thought it was really nicely outlined it. And what Dan essentially has put in this slide is, so what do I do, right? There's this shifting, let's use 4%, let's use 5% as cutoff for pH. Lyon classification, 6%. Well, how about 8%? How about just, I don't know, right? So I don't know what it is, so I'm just gonna shift the landscape, and that's a cutoff. Biological systems don't have cutoffs. Cutoffs are for us, right? We use cutoffs because it makes us feel good. Someone's dichotomously normal or abnormal, but it doesn't necessarily mean that it is the disease or it isn't. So can we do better? There's this conclusively they have reflux. It's supportive that they have reflux. I use MNBI, PSPW. I use, again, all the parameters that we know about. And by the way, if pH is normal, and there's a symptom associated with it, then we have hypersensitivity, and then we have functional. And that's defined by if the patient's symptom correlates with pH. I won't get into that. You already know where I stand on that. And then these cutoffs are problematic because we don't know what to do with those that have, quote, mild disease. I have a patient that has 7% total acid exposure. Do they have reflux? They didn't get better on PPIs. What do I do with them? Well, we struggle with some of those questions. So the MI technology really came about to say, can we look at it differently rather than pH, rather than impedance? Why don't we look at the mucosal integrity, i.e. what's going on in the mucosa? You can do it during endoscopy, patient sedated, you pass this balloon, which I'll show you, there's sensors, and it tells you whether or not the mucosa has been impacted due to chronic exposure of acid and bile, or if it's because of eosinophilic esophagitis or other diseases that may impact the epithelium. So I won't go through this. Dilated intercellular spaces. If you recall, one of the diagnostic tests was you biopsy and you see whether or not there's dilated intercellular spaces. Well, MI takes advantage of that. And again, it has been associated with spongiosis negatively, and that again corroborates. This is Dr. Katzka's study. This is the balloon, FDA approved in 2019. You pass this balloon into the distal esophagus, you dilate. There are sensors, 180 degrees apart, about 10 sensors on each of those strips that you see. And this is a view through the balloon from above. This is the data. These are the data. So as you see in blue, it shows the normal subject, eosinophilic esophagitis subjects. They have low ohms, meaning low integrity. In patients with eosinophilic esophagitis, you expect the entire esophagus to be impacted, and that is what MI shows you. And then in patients in green, that's the normal subjects or non-GERD subjects in this case, and you see that the mucosal integrity is intact as you would expect. So this is equivalent to your patient that you do pH testing, it's normal, you do endoscopy, it's normal, they didn't respond, and you tell them you don't have the disease, and that's what MI essentially will tell you. In red is GERD, which is low MI distally in the esophagus, which then becomes normal proximally. Physiologically, that makes sense because esophagus impacts distal esophagus more so than proximal, unless you have someone that has severe disease. This is a pattern, so it's designed to be recognized by pattern. Normal to the left, the cooler colors, GERD to the right, abnormal distally, proximally normal. And this slide really looks at the intercept versus the slope. So this algorithm that's in the program essentially looks at what I showed you, which is are the MI values low all across? That means low numbers at the intercept and low on the slope. Is it low at the intercept and recovers? That's GERD. Or is it high and high? And you don't have to worry about any of that. The algorithm within the machine takes care of that. And essentially, this is what you would do. During endoscopy, you pass the balloon. This is the reading. And then you get a probability reading. This patient's going to be normal. Cool colors, essentially intact epithelium all across. The next patient, abnormal all across. And again, the probability, as you see on the right-hand side, it says, I can't read it, 76% probability this is EOE. Again, consistent with what EOE should be, impact epithelium along the esophagus. And this is your GERD. And again, in this case, the probability is reading 65, I can't see it, percent GERD. The pattern makes sense. So the algorithm and the machine takes care of all of that for you. You don't have to worry about it. And now we've set it up so that essentially what you do is you pass the balloon down, you blow up the balloon, 5-second measurements, 6 of them, so it's a 30-second measurement during endoscopy when patient's sedated, then that gives you the probability. Then you take that probability, let's say this says GERD, then you say, well, all right, the patient has heartburn, they were responsive to therapy, this is GERD, I'm gonna send them to surgery or continue with their therapy, or whatever decision you need to make for the care of that patient. It's important to know that this isn't pH testing. Remember, we placed the pH catheter 5 centimeters above the squamocolumnar junction, or manometric LES, or 6 centimeters above squamocolumnar. Who came up with that? Somebody. It was arbitrarily decided, but logically, but arbitrarily decided. It isn't the same. A pH at a specific level will correlate with some of the MI findings, but they're measuring two different things. One is mucosal integrity, one is acid. One is measuring acidity or whatever during the 24-hour or 48-hour study. The other is measuring epithelial integrity from a chronic disease process. So remember that. I'm hoping we can simplify the math from this is what you do for your GERD patient. You don't need to know what this says to read it. It's just that it's very complicated. Is the SI normal? Is it abnormal? Is the SAP normal? Is it abnormal? Is it 6% or 8%? Did the patient respond? Didn't they? Should you send them to surgery or not? This is very complicated. I'm hoping the algorithm would be simplified to say, you tried someone on a PPI, they didn't get better, I did MI, and it's normal. Endoscopy is normal. They didn't respond to PPI. This is not GERD. Or they're not responding. When I take a look, there's a big hernia. They have regurgitation. That's why they're not responding. And MI may be altered. Maybe they need surgical intervention. So that's what we're hoping. We're not there. We need studies on outcome on this. So again, this at its infancy, it just got approved. And hopefully, if you like, you can join and do some studies to see where it fits in the care of our patients with reflux. And I hope that'll help us long term. Thank you so much.
Thank you for that. It is my pleasure to introduce our next speaker, but to this group especially, he needs no introduction. Steve DeMeester will be talking to us about failed anti-reflux surgery. But I will say, just to raise the bar for you a little, something that doesn't show up on a bio or an intro is his incredible ability to synthesize data and put it in clinical context. And so I always learn a lot. Welcome.
Thank you, Christy. Well, it's a great pleasure to be here. Really enjoy this conference. It's been fantastic, and I appreciate the opportunity to join this session. So, how do I work this? I guess I go forward. So, no disclosures for my talk. Obviously, I'm a surgeon, and I'm going to discuss some issues that I think are very important. And I want to start, before we really launch into things, I want to just set the stage a little bit. And actually took notes for this to make sure I get this right on track. So this is a super important topic, and I'm glad I get to talk about it. Because there has been an unfortunate myth pushed upon us. And in large part, that myth was pushed upon us by my very good friend, who I respect a lot, but I have to call him out periodically, Stu Speckler. So, Stu Speckler is in large part, or at least a co-conspirator in development of the myth that there's really no point to anti-reflux surgery, since they all recur and go back on PPIs anyway. So the origin of this myth really comes from his 2001 JAMA paper, which was a long-term follow-up of a randomized controlled trial comparing medical versus surgical therapy. And in a median of about 5 or 6 years in the anti-reflux group, he noted that about 62% of these patients were back on PPIs. He also noted that the cardiovascular mortality rate was increased in the surgical group. That was also a myth and has been disproven. But from this, we recognize the concept that symptoms after an anti-reflux surgery are relatively common, and PPI use is relatively common. But it's important, and we're going to make this point, that PPI use does not define GERD. And you just heard the other speakers talking about how you can have patients that are started on PPIs and are disproven or proven not to have GERD when you do functional testing. And the Achilles heel of Stu's paper was he didn't have pH testing, or not enough of it, to really adequately evaluate these patients. There's a number of studies, as we talked about, that disprove the concept that PPI use means you have reflux disease, and there's a number of studies that prove that anti-reflux surgery is actually very effective long-term. 10, 20 years out, we anticipate 90% of these patients still having a functional fundoplication. Now, the results do deteriorate when you do the operation in patients with more severe reflux disease. And we know if you have long segment Barrett's, more severe reflux disease, larger hernias, recurrence rates are higher. But they're still nowhere near under 50%. So it's a fallacy to think that all of these fundoplications fail and go back on PPIs. So that introduces the topic. What do we do when a patient comes in with recurrent reflux symptoms and an assumed failed fundoplication? So the first question you have to ask, and Stu, this is an important issue, Is it really reflux? What are the symptoms? Are they persistent? Are they recurrent? Are they new? Those are important issues in the evaluation of these patients. What is their heartburn symptom? Could it be esophageal distension? Hopefully most of you know that if you blow a balloon up in the esophagus, it will stimulate the perception of heartburn. Well, what happens when you put a brand new fundoplication on somebody? You increase outflow resistance. And if they eat too quickly, they can experience a sensation of heartburn. It's relatively common, particularly in the first couple months after a fundoplication, and we know that that is esophageal distension, not true heartburn from reflux. Is it a persistent symptom, or is it new? New symptoms or persistent symptoms you have to think differently about. What about regurgitation? Is it bland or is it bitter? A very important question. If it's bland regurgitation, it never made it to the stomach. That's an outflow resistance of your nissen. If it's bitter, okay, that may be true regurgitation of gastric contents. Is there dysphagia? Is it a tight fundoplication or a tight curl closure? Or is it perhaps related to an anatomic problem, a recurrent hernia, or a slipped or misplaced fundoplication? So those are the kind of things you need to think about. What are the symptoms specifically? Are they brand new? Are they persistent? Are they recurrent? Obviously, recurrent symptoms, a little more concerning. I had heartburn, it went away, now my heartburn's back. That's a little more concerning for a true recurrence. And then the timing of the symptoms. We alluded to that a little bit earlier. Early symptoms, like early heartburn, probably esophageal distension. Later symptoms, heartburn went away, a year or two later, heartburn's back, more likely to indicate a failed fundoplication. So then we have to ask the question, well, has the fundoplication failed? And that's a tough question a little bit, but there's three forms of failure I want you to consider. There's anatomic failure, there's functional failure, and there's symptomatic failure. And we'll dive into each of those a little bit as we move along. So the first important point, Stu, symptoms don't equal reflux. Patients with GERD have a variety of symptoms. They may have extraesophageal symptoms, some cough, some LPR symptoms, some globus. They may have chest pain. They may have a variety of symptoms. Only symptoms related to reflux disease will be expected to be resolved with a fundoplication, which is why things like cough and chest pain are not nearly as reliably resolved as things like heartburn and regurgitation. So recognize that symptoms don't necessarily equal reflux. A fundoplication only addresses symptoms related to GERD. And in this nice study done by Reg Lord from our unit, after the Stu Speckler paper was published, we actually looked at, with pH testing, a series of 86 patients returning with symptoms after a fundoplication. And you can see the percentages for heartburn, dysphagia, pain, and so forth. Median interval from surgery to evaluation was about 1.5 years, and only about 1/4 of those patients had a positive pH test. Many of them were back on PPIs. So being back on a PPI or having a symptom after anti-reflux surgery does not mean you have reflux disease. You need to do a pH test. Now down the road, maybe we'll use a mucosal impedance to evaluate these patients. That's a new exciting area for us to explore. But the reality is at least 75% of patients that are either taking a proton pump inhibitor or have some symptoms after anti-reflux surgery have a perfectly functioning fundoplication. Now, if you do see abnormalities on an upper endoscopy, that changes the game a bit. So I think an upper endoscopy is a critical component of evaluating patients with recurrent symptoms after a fundoplication. If they have severe esophagitis, CD esophagitis, clearly the fundoplication has failed. When you do your endoscopy, pay attention to the location of the gastroesophageal junction to the pinch of the fundoplication, the relationship between those two. They should be very much aligned or very close to each other. If you see the GE junction well above the pinch of the fundoplication, that's a slipped fundoplication. I'll show you some pictures in a minute, but that's a really important thing to watch for. Is there difficulty passing the scope through the fundoplication? Does it suggest it's tight? Is the nissen tight? Is the curl closure tight? What does the fundoplication look like on retroflex? critical part of an upper endoscopy evaluation after surgery. Is the valve symmetric? Is there a twist or a spiral? Is there a recurrent hernia? Is there excessive bulk of the fundoplication suggesting perhaps it's a little low or slipped down? So those are critical things. And for those of you not really familiar with what these should look like, here's some examples of an intact fundoplication. Nice symmetric appearance to the valve. On the far right is a callus fundoplication, and you can see the very tall appearance of that callus fundoplication, because that callus is an extension of the esophagus and gives you that very stout appearance. And sometimes toupees can look a little fleshy and large like that. If you see a very bulky fundoplication, though, you have to be a little bit concerned about perhaps a slip fundoplication. If you can see the squamocolumnar junction on retroflex, there's no way the valve is low, right? Because that means that most of that fundoplication is above the GE junction where it should be. You can't always see the squamocolumnar junction, obviously, because it can migrate cephalad, and you won't always see that. But if you do on retroflex with a fundoplication, there's no chance that fundoplication is low. So that's an important thing to note if you see it. Of course, you'll never see that with a callus gastroplasty because that callus is gastric tube. Now here's anatomic failure. So on the left image, you have a slipped fundoplication. You can see the squamocolumnar and gastroesophageal junction, the top of the rugal folds in the foreground, and distally, you see the pinch of the fundoplication with a little bit of gastric juice or something sitting down there in that pouch. That fundoplication is too low. It's too low by about 3 centimeters. That patient is going to have a combination of dysphagia and reflux. It's a sine qua non, essentially, of a slip fundoplication when they have both dysphagia and reflux. Middle image is a recurrent hernia. You can see the fundoplication is intact, but the curl repair has broken down and portions of the fundoplication are herniating up in the chest. And the far right example is a disrupted fundoplication. You can see how it's partially herniated and disrupted in that patient. So anatomic failure, very important, best identified with an endoscopy. Functional failure is a little bit different. This is an intact or perhaps maybe slightly disrupted appearing fundoplication, and then you do a pH test and there's increased acid exposure on pH testing. So objectively, on anatomic opinion, it's pretty intact, but functionally it's not working. And in the reverse, you can have intact fundoplication, but persistent dysphagia symptoms and evidence of esophageal outflow obstruction on swallow study upper GI or perhaps on your manometry. And that would suggest perhaps the Nissen was made too tight or too long, or perhaps the curl closure was too tight, or perhaps that patient has poor esophageal motility and a Nissen causing those outflow issues. And then we get into the really complicated group, the symptomatic failure group. This group has a normal appearance to the fundoplication, normal objective testing, meaning their pH test is normal, they don't have increased esophageal acid exposure, there's no suggestion of esophageal outflow obstruction with upper GI or high-resolution manometry, but they have persistent troublesome symptoms that were expected to improve. Now that's an important issue. As surgeons, you've got to go through the symptoms with your patients preoperatively and tell them what symptoms you expect to get better, what symptoms might get better, and what symptoms probably won't change. If you don't set those expectations, you're setting the stage for a dissatisfied patient who thought that all my symptoms are going to get better when I do this surgery. Very important to outline which symptoms are probably very clearly connected with your reflux disease, which ones not so much, and which ones probably not. Set that expectation preoperatively and avoid this problem. So if you have these persistent symptoms, now sometimes you also get side effects. So you can get bloating or post-operative diarrhea, which is usually self-limited but can occur for a couple months. So you can have some of these troublesome post-operative side effects in addition to other symptoms that didn't go away. So my algorithm for evaluation, early dysphagia, reassurance, unless it's really severe and they're struggling to get anything down, then we consider an upper endoscopy and a dilation. Early heartburn regurgitation, again, reassurance. Drink warm liquids with your meals. It usually settles down. Late heartburn and regurgitation, more concerning for a recurrence. And then we're going to start our evaluation, upper endoscopy, pH testing, upper GI. Late dysphagia, again, likely related to some new process, perhaps a stricture from recurrent reflux, perhaps something more sinister. So again, you're going to do an objective evaluation. High-resolution manometry in selected cases and gastric emptying study in selected cases or before reoperation to document the function of the stomach. So how do we treat recurrence? It's much more likely to recommend reoperation for anatomic or severe functional failure than symptomatic failure. Most common form of anatomic failure is a recurrent hernia. Often these are minimally symptomatic, and pH testing confirms the fundoplication is effectively controlling reflux. Reoperation when recurrent reflux is documented, or there's new onset dysphagia or other symptoms thought to be related to a recurrent hernia. It's important to review the prior op note, understand how the cur was closed, whether the esophagus was thought to be short, whether there was mesh used, in understanding how you're going to approach this reoperation. Any new operative plan should address the likely cause of failure in your mind. Are you going to use mesh? Are you going to need a crural relaxing incision because the hiatus was very difficult to close the first time? Are you going to need a cholecystroplasty because of concerns of short esophagus? I think it's really important to avoid the I can do it better approach. Oh, I'm an expert, so I can do it better than the guy that did it before. That generally gets you in trouble. Remember Einstein's definition of insanity, doing the same thing over and over, expecting a different outcome. So do something different. Understand why it failed and make sure you do a different approach. Persistent or recurrent heartburn with abnormal pH test, acid suppression medications, always the way to start originally. Review the operative note again. Consider reoperation only after an understanding of why the first operation failed. Persistent or new onset dysphagia with esophageal outflow obstruction. Assess for esophagitis or stricture as the cause. Severe malnutrition, they might need a PEG tube preoperatively. Again, review the op note, understand, work the patient up, know what your repeat operative plan would be. For symptomatic failure, go slowly and carefully. Many times you're not going to fix these problems. You can review the original symptoms, the original operative note, try to understand what symptoms are persistent and what ones are likely related to reflux and should have gone away and which ones aren't. But be careful with your revision. Post-fundoplication side effects, bloating and diarrhea oftentimes improve with time. If patients complain a lot of bloating, you don't know if it's the colon or the stomach. I'll send them to an ER when they feel like they're significantly bloated to get a KUB to make sure it's not colonic distension versus gastric distension. If you prove it's gastric distension, I've had great success putting a PEG tube in these patients so they can vent. And usually after a couple months, you can take the PEG tube out and they're fine. Reoperation, John Lippman wrote a paper about conversion of Nissen to Toupet, or perhaps a Lynx procedure in some of these patients with significant symptoms, and that was successful as well. So in conclusion, the best therapy for recurrence after a fundoplication is prevent it to begin with. Select your patients carefully. Really don't skimp on your evaluation. You know, this is a lifelong disease and we're after a lifelong therapy, so don't skimp on your evaluation. Make sure you understand what's working, what's not working, so you can provide the optimal therapy for this patient who comes to you seeking relief of their symptoms. Do the operation perfectly, don't settle, don't compromise on your crural closure, don't compromise on a short esophagus. Recognize the most common form of anatomic failure is a recurrent hernia, even in a small hernia patient to begin with, so do everything you can to avoid that problem. And then lots of reassurance goes a long way in the early postoperative period, particularly when you select your patients well and you've done the surgery nicely, you know the expectation should be good, so walk them through it, and most of the time, things will settle out. Thank you very much. Pleasure to be here.
Yeah, I think we should bring Stu up. Stu, get to that microphone.
We're not kidding. Come on, Stu.
I actually thought Stu made some headway with his New England Journal paper where he had a randomized controlled trial. You guys still have not forgiven him.
Oh, we love Stu. It's just, you know, he takes things out of context and he doesn't dive to that next level. Like, for example, yesterday I said, nobody needs an anti-reflux surgery.
That's what I was going to say.
But the point
we've
is,
come to agreement.
there's lots of people that would be hugely benefited by it. The quality of life is dramatically improved with a fundoplication or a LINX in a lot of these patients. Why do you hold them up so much? Send them for the quality of life improving treatment we can offer.
No. Well, thank you. Believe it or not, Steve and I have become very good friends over the years. And I wish I had it on tape, you saying nobody needs anti-reflux surgery. That was great.
Need is the key word.
Need, he said. Yeah, I remember. Need.
But let me say this. You remember, at the time that study was published, anti-reflux surgery was being touted as the permanent cure for reflux disease. And you know, I have changed my thinking on this over the years, and when it's done in the right patient for the right reasons, and as you said, that's absolutely the key for getting good results to this operation. And the patient has to know that not every symptom that they have, because they have reflux disease, not every symptom is the result of reflux disease. But there are a lot of expectations, and actually, I think that study went a long way to where we are now in understanding this disease a lot better, because I think that we had too much expectation for it. And now, you know, knowing what it is in the right patient, it's a wonderful operation. And I send a lot of my
Stu.
patients.
Thank you.
All right. Reconciliation.
I'm going to give you a big hug.
Okay.
All right.
Later.
Well, I mean, he makes a good point. The paper did influence everyone to raise the bar and really do good studies. I mean, you guys did that study right afterwards. So we all, as Tom DeMeester says, the mind sharpens the mind. So.
All right. Question from the audience.
Yes, hi, Roger Tatum from Seattle. Steve, great presentation. I agree with all of your points. I also agree that nobody truly needs a fundoplication. I've told many patients that, but there are a lot of patients who really benefit from it, and actually one of Dr. Speckler's other papers has demonstrated that, which is nice. My question is related to the patient who comes back after failure with a second fundoplication. And this is quite an area of difficulty for a lot of us, I think. Those patients will come back sometimes with pretty terrible symptoms. Sometimes they'll have had another anatomic failure that you can demonstrate. I personally tend to be very reluctant to operate on those patients, except under very specific circumstances. And I want to know what your thoughts are on whether there's sort of a threshold for number of reoperations, realizing that the success rate really goes down every time. And if there's anything in particular that you do different, especially if the recurrence is one that you yourself know that everything was done to the best of your ability, but it's hard to come up with a solution for what's going to make it not recur a third time if you undertake that.
Yeah, no question. I mean, there's been some nice studies. I think it was Alex Little published one of the first ones showing that the results deteriorate with each attempt. More recent studies, and we've been trying to collect that data ourselves, I don't think there's a big drop-off between 1 and 2. Probably between 2 and 3 you're going to get a real drop-off, I agree, and beyond 3 for sure. So I think in today's world, particularly with laparoscopic surgery, a third-time redo is generally not out of the question. I agree 100%. Put them on PPIs, see how they go. I mean, you got to convince them that their quality of life has to be really impaired, because, you know, things can start going ugly on reoperations. And when you get to the third or fourth, I usually talk to them about Plan A and Plan B. Plan A is we're going to redo your fundoplication. Maybe you need a cholestastroplasty, sort this out. Plan B is the tissues go to crap. I got holes in the esophagus, holes in the stomach. You're going to end up with an esophagojejunostomy, or maybe I'm going to do Roux-en-Y, gastrojejunostomy, put a new fundoplication on there, divide the stomach just below the fundoplication, and do a Roux-en-Y to assess some gastric emptying issues. So it gets complicated, 100% agree with you. There's no clear-cut algorithm, but I wouldn't deny somebody who has really impaired quality of life a multi-redo operation.
Mm-hmm.
Thank you.
Question?
Peter Corellis. My compliments to all the speakers. I think these were very circumspect talks, even yours, Steve.
Well, thanks, Peter.
Very good. Wow. I have a question, though, for Michael Vasey about MI testing. It seems absolutely critical to me that this be timed with respect to when PPI therapy was ceased. Because otherwise, the result you get is going to be entirely dependent on the treatment effect.
Yeah, so what you're saying is you should do the test off therapy, is that right?
For some specified period of time, because you have to assume that you want to get it back to baseline, whatever that was.
No, that's right. So where we are, someone is on therapy, not doing well, they have symptoms. We do impedance pH testing, the catheter, and we say 75% of those tests are normal. We say you don't have the disease, right? So you could do it on therapy, and likely mucosal integrity will tell you you don't have the disease because they don't have the disease. So I think it makes sense to do it off therapy. Depends on pretest. If pretest you want to show the patient has the disease, or do you want to show that they don't have the disease? In most of the patients I see, they're coming because of chronic cough, LPR, GERD, all the things that we talked about, and they don't have the disease. 20% do, 80% don't. So my point is to make sure that I tell them they don't have the disease, taper their medication.
When you say the disease, what do you mean?
Yeah, that was the question I asked you about 15 years ago, Peter. I wasn't going to tell them who it was. What is GERD, right? So right now, what do? So we do the test. So let's say impedance pH on a patient on BID dosing is abnormal. What do? The patient didn't respond to BID. So what is reflux? You know, who do I send for surgery? Do I send someone that has impedance pH that's abnormal, pH at baseline that's only 7%, but symptoms didn't get better on BID dosing? Would you operate on that patient? If the answer is yes, then we're doing all the right things. If we're not frustrated with our patient care, then keep doing what you're doing.
We actually wrote a paper that heartburn symptoms, classic heartburn symptoms with a positive pH test, unresponsive to PPIs or poorly responsive. Typically, it's like it responds, then it doesn't. They switch PPIs, you get a little relief. Those patients do exceptionally well then in reflux surgery. Yeah. And I got another question, follow-up question for you. You talk about the 4%, 5%, 6%, 7%. Where do we draw the line? I heard rumors that some guy developed a score. What is the resistance to using a score, which gives you a clear-cut, not sex, gender-dependent answer on whether you have reflux disease or not? Seriously, why don't you use it?
Yeah. No,
What's the resistance?
Your point is right. I think at the end of the day, what we're all aiming is to find out who has the disease. And then we can discuss what the treatment options are. If I know that this person has reflux, then I can talk to them about PPI therapy, surgical intervention, endoscopic intervention, all the options we know. But where we are, we're offering surgical or endoscopic procedures to those that don't have the disease. Oh, you didn't get better, let's do this other thing. And guess what happens? They don't get better. They fail, technically, or they fail because we enroll the wrong people to have the wrong test. So
it's the old adage, man.
Right.
Diagnosis should precede therapy. And you got it backwards. We're throwing PPIs on people out of diagnosis.
I agree.
Yeah, it's true. Just want to be respectful for time with questions. So next question.
So I have a comment about the surgery. There is no question, I think, that surgery works. What it's supposed to do, it does it. Now the question is how it does it. That's another issue, whether we really understand how fundoplication prevents reflux. There is no question it does. My comment is related to also to Stu Speckler's paper that has come into limelight, that surgery done for non-acid reflux. Now, people who underwent surgery for non-acid reflux, they did much better than people who did medical therapy. So one interpretation is that surgery prevented non-acid reflux, and that's why they got better. That's why their symptoms better. But it has never been proven that actually non-acid reflux can cause symptoms. And this comes back to what is really the cause of the symptoms. But surgery did do something that even if the non-acid reflux was occurring, it made their symptoms better. So maybe another interpretation that I would like to think that surgery worked in those patients by some other mechanisms than by just addressing reflux. What are the other mechanisms that may have caused symptoms in those patients? You know, you guys, when you do the surgery, you do a lot of things. You disrupt the phrenoesophageal ligament, you close the hiatus, you wrap the fundus on the stomach. So any of these things, a lot of these things, could prevent the symptoms. We really don't understand
No
the
question.
genesis.
That's a high-level discussion, but I will say you got to define the symptoms. Anti-reflux surgery stops regurgitation symptoms. Acid, non-acid, doesn't matter. Stops regurgitation. So you got to define the symptoms a little more. But that's a high-level discussion and probably too much to take on right now.
No, I'm not. I'm just making a comment, and I'm not expecting you to answer because we don't have an answer as to what really causes symptoms, the genesis of heartburn. And we assume, and everybody assumes, heartburn, reflux. Let's do PPI, let's do surgery. But that's not necessarily the case.
Well, that's part of why pH 4 was chosen. Acid reflux with a pH less than 4 tends to produce heartburn symptoms. So some of that data is out there.
But there is a lot of heartburn that is not related to acid reflux.
For sure.
Or non-acid reflux.
If I may make just a quick comment, I think there's a fairly robust body of evidence showing that weekly acidic reflux does cause symptoms. Even in meta-analysis form from hundreds of patients, there are what we call non-acid reflux is often weekly acidic reflux with pH 5 or so that can still stimulate chemoreceptors. Distension from the reflux volume can stimulate mechanoreceptors. All share a common pathway, and the esophagus is not a very sophisticated sensory organ. Something happens, you're either going to feel heartburn or chest pain or regurgitation. So I think weekly acidic reflux on BPI has been clearly shown to provoke symptoms. There are many other reasons for symptoms. And then the data I had shown you in my talk does show that if you reduce reflux, this is with the LYNX experience, to less than 35, in those that have had a high reflux burden, that they will do well. So I think there is some fairly recent data showing, the value of that. Of course, there are many other reasons for symptoms, but we shouldn't lose track of these data.
Yeah, I mean, especially regurgitation.
Well, it's important to understand that, yes, any of this composition of reflux can cause symptoms, but the purpose or one of the huge utilities of the pH test is that it is a prognostic indicator to how they will do with surgery. Sorting out those weekly acidic ones, the functional ones, yes, some of them are going to do great with surgery. A lot of them won't, and that's where we all have to keep having this meeting every year, talk about it.
Next
Oscar?
question.
Yeah, it's a great debate. It's wonderful to be in a venue that allows debating between the specialties. It happens all too infrequently, and only a few. I just wanted to bring up the second great myth of post-surgical symptomology, which is that the surgeon must have done something wrong. Surgeon must have cut the vagus. Because that's very uncomfortable for the surgeon and puts them in a very bad position. How do you work those patients up? Does that really happen that often? And what role does that play in the whole thing? Thank you.
Well, Lee, I know you know the answer to that already. But we know that cutting one vagus has almost no implications. In fact, Pellegrini wrote a paper suggesting that if the esophagus is short, one option is to cut a vagus and you get 1 centimeter. Cut both vaguses and you get 2 centimeters. So you can increase esophageal length by cutting the vagal trunks instead of trying to mobilize way up high in the mediastinum, dividing those vagal branches to the pulmonary hilum. And in that study, there was only about, I believe, 40% of patients with both vagus nerves cut had any type of significant gastric outflow symptoms. So the vast majority, number one, on a simple, straightforward fundoplication, almost nobody has both vagus nerves cut. Almost nobody has one vagus nerve cut. Complex paraesophageal hernia, yeah, one vagus might go. Pretty rare to get both. The vast majority of patients with gastric symptoms after a fundoplication, it's not related to vagal nerve injury. In fact, on these paraesophageal hernias, when I do a collis, I scope everybody at 3 months looking for any esophagitis. Very commonly in these big upside-down stomachs, when you fix them, I see food in the stomach. I think these upside-down stomachs don't function well when you restore them, and I know their vagus nerve was not the issue. So vagus nerve issues should kind of be put to bed in general for anti-reflux surgery.
Yeah, I think your emphasis on the EGD and looking at the anatomy is extremely important. I think that's one of the things that's poorly taught, at least in GI fellowship. It's something that I think it really tells you what's going to happen. Because if I do a retroflexion and there's an intact fundoplication, those people, I'm not going to say never because you always get burned and say, but rarely will those people have a positive pH test. It doesn't matter. They rarely have a positive pH test, rarely have a positive pH impedance test. So I mean, I agree, when you see that. And going back to it's really expectations. And even you didn't go so far to say that you would send them to a psychologist Steve, but you were getting there. You're moving along. And that's the point, is that it's a lot of expectations. And, you know, you have patients who get rid of their heartburn, you know, and they have a little bit of gas bloat after that. That's not a catastrophe, and you have to make patients manage that and self-manage that. So, question.
Mary Maish from Lake Forest Hospital, Northwestern System. Steve, great talk as usual. Rare to find a talk where somebody just regurgitates everything that you're thinking in your head, but you did that. I couldn't express more of an alignment in the fact that the prevention of problems for recurrent surgery start with good patient selection, and I would say that for every GI specialist who's never sent me a patient, I've had several send them saying, she's going to fix everything, and then I have to tell them, hey, you know, I actually can't fix that symptom. So I do think that's really important. But I think even more is your comment on prevention by doing a good first operation the first time around. And I'm sure there's plenty of people in this room that feel very uncomfortable doing more skilled procedures like a Collis, Nissen, and even the relaxing decisions that you advocate. And I wonder if you could speak a little bit onto how those of us that are in the audience here today, and maybe some that aren't, could gain some experience in that area so that we could do a better job of preventing hernia recurrences altogether. Thank you.
Well, that's a huge challenge. You know, post-residency education for surgeons, probably GIs too, is a challenge when new techniques, new technologies come along, and we as a society, I think that's the best option. You know, we try to teach these courses, and in our Hawaii course, registration was just released today, by the way, if you want to come out in Hawaii in February and have a great time discussing all this stuff. But in any event, I think we got to do a better job in some of these courses, because post-residency education is a challenge. Next question.
Thank you for such a wonderful degree of sort of discussion on this. And this, I guess, kind of coming back to your point, Dr. Demeester, about discussing symptoms, and Dr. Pandolfino discussing sort of behavioral therapy. The patient that comes to you, positive pH test, some response to PPI, but all of their symptoms are extraesophageal. They're complaining of cough, they're talking about things in the back of their throat. What additional sort of testing do you feel like you need for those patients besides just the symptom discussion? Is there anything else that we're looking at right now that we should be doing before we get these patients into surgery, even if they have proven acid reflux?
That's a great question, and I would pose it to my panel because I was actually going to ask that question if nobody did.
So let me give you a quick example of a patient that had 20% acid reflux, had chronic cough as the main symptom, had a 5-centimeter hiatal hernia. I said, and not better on PPI with regurgitation, cough and regurgitation. I said, PPIs don't get better. I have enough evidence of regurgitation, go surgery. What I'm about to tell you is not that they got better. Their cough did not get better. So there is cough-related acid disorder, i.e. acid causing the cough, but in many of our patients, it may be true unrelated. So you're sort of stuck on, what about the patient has no hernia, mild reflux at best, not responsive to PPI? My recommendation to the group would be, don't touch that patient if you're a surgeon. Now, you could say, I'm gonna, but do then treat their cough afterwards. And you don't, and that's the problem, right? Because then you send the patient back and you say, well, it's not reflux. Well, it wasn't reflux to begin with. They had reflux physiologically, but it was true unrelated. So,
yeah, I think that's an important point, because the supraesophageal or the cough, the pulmonary symptoms can be a final common pathway, and reflux may be just one of the instigators. And so if you fix one of the instigators and the patient still has postnasal drip or something else, their cough's not going to go away. So I think the best resolution, the best solution in that setting is, if evidence is not conclusive, like Mike talked about for reflux, or if they don't have a typical symptom, then it's probably best not to mess too much with them and try to treat their cough symptomatically with measures that John talked about, some of the cognitive behavioral therapies, neuromodulators, and see if they get better.
That's a super important point, but yeah, let me just...
Can I interrupt for 1 second? I think this group in particular is very aware, all of us, surgeons, GIs, that it's 50-50. I think the question is, help us? Is there a diagnostic tool that you guys have found it helpful? Like we try the ResTech, I don't know. So far, after all these years, I still am at the point where I tell the patient, it's 50-50.
Yeah.
Is there anything better?
I'm not sure.
Not necessarily. We can talk about the test
50-50.
guidelines and the cough and the thing, but is there a good test, is what she's asking.
I think
No,
it's a
so
combination.
ResTech, yeah, go ahead. Yeah.
I think it's a combination, accumulating more evidence. I don't think you can go by a test. I think you have to go by the patient's symptom, their background.
Let me just
the
give
answer
you
is
some
no.
thoughts here. Let me just unify this a little bit.
There you go. No, Missy.
No question, reflux disease can be associated with cough, extraesophageal symptoms. The problem is there is no test that will tell you what degree to which that reflux is associated with that symptom. That's the problem. They can be associated, but you don't know what degree.
Yep.
Frequently, those symptoms are multifactorial. I tell my patients it's very unlikely all of your cough or whatever extraesophageal symptoms related to reflux. It might be, but very unlikely. Usually, it's multifactorial and other factors are participating. The problem is I can't tell you how much reflux is participating in this, and even worse, sometimes reflux potentiates the other problems by creating inflammation such that 1 and 1 don't make 2. You might have some postnasal drip, but that's trivial, but the reflux is hypersensitizing the laryngeal tissue so much that it feels like a 5 to you. And I get rid of the reflux and you go to a 1 rather than a 4. So it's a very complicated area and you cannot assure patients it's going to go away. If they have proven reflux, very likely there'll be some improvement. How much? Very unpredictable.
Managing expectations is the key.
Exactly.
I mean, I've had patients that I tell, they have hernia, high acid exposure time, heartburn, cough. I tell them, I think we have justification for an intervention. You have objective documentation of reflux. Your heartburn, I feel very strongly, is going to get better if the operation works, and it usually does. Your cough, I don't know, but we'll see what's left, after that.
I was hoping Sumi would come up and maybe talk about his publication and experience with the redo operations, but
Actually,
Steve
has done a great job.
Yeah.
I'm not going to talk.
Right.
I want to talk about the Dr. Mike Vezesi, who said, I agree with Peter when he said that a test needs to be standardized in the condition it gets done. Trying to do a test with or without PPIs, knowing what you want to find is probably not the most ingenious way. For the person you said who has extraesophageal symptoms on PPI don't get better, do it on PPI. In fact, it should be the completely other way, that you want to see whether the acid reflux is causing mucosal damage. So I think I will go with Peter that we should define that the person should be off PPIs for an X number of days, H2 blockers for X number of days before we do the testing. And just want to elaborate, why would you not want to do that?
No. You would always want to do tests off therapy prior to any endoscopic or surgical intervention. The comment I was making was, if you do it on therapy, but you don't have off therapy data, you don't know what to do with the on therapy finding. That's important, whether it be impedance, mucosal, or what have you. I think you have to do the test off to show physiologic, whatever that is, combination of findings before you intervene.
Forget about surgery. I'm not talking about surgery right now. Somebody comes with extraesophageal symptoms, reflux.
I would do it off therapy.
But you said do it on therapy.
No. I was using an example. No, I was saying if you want to show pre-test, post-test, if you want to show the patient doesn't have the disease, you could do it on or off. But remember, we did a study with pH testing. We found that chronic cough patients, solely chronic cough, 50% will have abnormal acid exposure. So what we're telling them is, you didn't get better, but you have reflux. Now they're confused. So you could do it off, but put it in perspective. You could do it on, put it in perspective with their symptom and their treatment response.
What do you think about 96 hours, 48 on, 48 off?
Yeah, so you could do that. That depends on your resources, right? So if you have plenty of Bravo boxes and what have you, the longer you follow, you're increasing the sensitivity of your test. John's data show that if you're more than 2 days abnormal, that's great because you're increasing sensitivity. My issue is I want specificity. I don't want sensitivity. Before I send anyone to you, I want to make sure that I have a test that told me for sure if they have the disease or not, and also that they really don't have it before I send them to you, or not send them.
So that patient you think doesn't have reflux disease, pH testing, whatever, You have the extraesophageal symptom, you put them on therapy, they don't get better. You do it on therapy, it does not show mucosal damage. I don't know how does that change my plan. I would still want to look for acid reflux.
Why?
To see whether, so if they don't.
How will that help you
so
in managing the
mucosal
patient?
damage improve with acid suppression?
But the cough didn't get better. That's your main symptom. It didn't get
But if the person
better.
had heartburn also, I'm just saying, we can have different things we're treating in the same patient, right?
But symptoms are important. It depends on which symptom, right?
So how would, when would you expect the mucosal impedance to be positive if you are
Off therapy, more likely.
So
Off
why? I just don't accept doing it on therapy unless they have eosinophilic esophagitis.
But then you don't have to do it that way. You have the option to do it however it fits your patient population.
No, I want to tell them you don't have mucosal damage, put them on PPIs.
All right, this is a great argument. And I would love to sit here all day and listen to it. But I know Tom and Felice are going to get angry with me.
John, can I make a quick... I have...
Sure.
You know, I think the question really is what's causing patient symptom.
That's right.
The question is not whether patient has reflux or not. And this is the problem right now. You know, we do the pH testing of the therapy, right? So patient is not responding to the PPI therapy. And you do the pH testing and he's got a lot of reflux. And you do the pH testing on therapy, there is no reflux. So we have really not addressed the patient's problem. We are addressing the parameters of pH. So the mucosal integrity should be done on PPI because patient is currently having symptoms.
That's right.
Yep.
And if the mucosal integrity is normal, that tells you symptoms are not due to the reflux.
So let's conclude by saying that there's different reasons to do these tests on and off, depending on the scenario. But I think sounds like we all agree, before you operate on them, they better have an off-medication abnormal pH test.
What a fantastic session we have had, and that is testimony by the questions.
She's the chair.
I cannot thank this panel enough for such a stimulating experience, and for the questions in the audience, and certainly they will be available to answer, to continue to answer these questions that will go on forever, it seems. Felice Sussman, it is my pleasure to introduce Dr. Philip Katz to the podium. I want to tell you something about, they're so noisy back there. I want to tell you something sort of amazing that actually happened that is a product of your society, the American Foregut Society. It is no small accomplishment to even think about starting a journal. But it is an enormous accomplishment to be able to create one in a short amount of time. And that is what has actually happened, from just a pipe dream to actually an in-production journal, which I think some of you may actually have at your seats. But if you don't, you should actually make sure that you start to read it. So Dr. Philip Katz and Brian Louie are actually the editors-in-chiefs of the journal, and it's my pleasure to actually introduce my partner, Philip Katz, to the podium to speak about the journal itself, and I think probably the vision of what the journal is going to do for our society. And I know that this is going to be a journal for us, one where we're going to have an opportunity to not only submit, but also read about topics that are just essential to our patients and ones that we hold so closely. Thank you so much, Philip Katz.
Thank you, Dr. Schnoll. My goal in the next now 9 minutes and 50 seconds or less is to introduce you to your journal and to thank the executive committee, the board, and the society for allowing me to participate in this venture. The slide in front of you will stay up. Dr. Schnoll Sussman has shown you the cover of the journal. She's indicated that the first issue of the journal was produced on a very, very short timeline. In fact, the authors were commissioned in September and we published in March. So the real credit goes to the people who wrote. But I want to introduce you to the editorial board. as an illustration of the collaboration goals of this journal, just like the AFS and this meeting that we've all had the privilege of being part of so far. My major kudos go to Brian Louie, who could not be here today because of a travel ban. Brian is the surgical co-editor of this journal and has been an incredible partner. Without him, this journal would never have been produced. He has been yeoman, as have our two senior associate editors, Kerry Dunbar and Virginia Lytle. Kerry is in the audience. Virginia, now in Utah and Intermountain Health, is giving the thoracic boards this weekend and could not be here. And if you look at the editorial board carefully, you'll notice a 50-50 balance of surgery and gastroenterology. And that was our goal from the beginning and will continue to be our goal. One of our associate editors is in the audience, Dr. Ayazi. The others could not be here. Dr. DeMeester, who gave an elegant talk on the approach to failed anti-reflux surgery, has generously given of his time to challenge us in the way that Steve might to create a unique journal. And the editorial board, all of whom at this point have volunteered to write, save a couple, but your turn is coming. I thank you in advance for putting energy into helping us start this journal. So the goal is to create a journal that is different, a collaborative journal that will emphasize the balance or lack thereof between the surgical approach and the GI approach, and attempt to reach a practice consensus and create a journal that illustrates those issues. We will publish quarterly for years 1 and 2. Many of you know that 2 issues have been published. We had hoped to have issue 3 for you on site, but it is not quite ready yet. And we hope to go to 6 issues per year going forward, and then we will accelerate or not depending upon the success of the journal, which will be defined by submissions. Now, all of our issues will be thematic, at least through issue 8, which means that you will read best practice reviews. They will be written by people who are by consensus experts and will be volunteering their time. Issue 3 will be on issues related to motility. Issue 4, which is coming, will relate to bariatric issues and the interaction with GERD. Issue 5, or Volume 2, Issue 1, will be devoted to hernias. Issue 6 to esophageal cancer. Issue 7 to achalasia. All authors have been commissioned for up through issue 6. So we are moving very rapidly, and you should look forward to that. We will publish original research. At present, we are gaining momentum, and you will start to see original research articles coming. All of them will be reviewed by a surgeon and a gastroenterologist, and will be done so blinded, both to the author and to the reviewer. So you will see those. There will be How I Do It articles, and we will encourage people to submit How I Do It articles. Rarely we will publish case reports of very, very supreme interest. You should know if your case report gets rejected, it may not be because we don't like it, but because, for better or for worse, impact factor is affected by case reports in a negative way, and ultimately we will need that to sustain the journal. And we will have editorials, and I encourage all of you, when you read, to write letters to the editor. So as part of your membership benefit, you will get this issue online. There'll be limited paper copies. There are some out there if any of you would like to read the old-fashioned way. And you can access this through the AFS website. I promise you it's not simple, but if you have trouble doing it, while we try to simplify it, just email, not necessarily me, but email the AFS, and we will do our very best to get you engaged. Our publisher has done their best to work with us to make this as seamless as possible. Now, here are our first issues. I apologize for being repetitive. Now, what we need from you is to read it. And we need you to read it so that A, you can write letters to the editor, and B, we can get interchange, maybe translated to Doc Matters or to other media, and most importantly, to give us feedback. We may ask you to write. We ask you to strongly consider our request. We started with giving people 60 days lead time. We're now up to 4 months. So we're going to be able to give you appropriate lead time to write a state-of-the-art article or a commentary. So please consider our request. It will help us move the journal forward. And most importantly, please review for us if we ask. It is not a simple thing to do a review. I understand that, and many of you are busy and have not done a lot of reviewing in the past. Please consider that request. Without peer review, A, we can't be above board, B, we legally can't get indexed, and C, we can't get our papers done. And then finally, please give us feedback and suggestions. As we go, we will modify, we will adapt, and we will respond to your suggestions, which can be done through the website. Look for highlights on Twitter, look for highlights on Facebook, whatever social media I don't use that you use, we will be highlighting issue, we'll be highlighting what's in the issue, and it will be a way for you to comment and by all means to spread awareness of the journal as a mechanism potentially to bring people into the society. So with that, Dr. Schnall-Sussman, Dr. Karillas, the entire board, Brian and I thank you for the opportunity. Keep your ideas coming. It's been a very, very fun ride, and I hope you enjoy the journal going forward. Thank you all very much.
Beautiful.
Thank you.
All right. Well, it is my great honor to introduce the presidential address. A little bit of background about the president of the society. It's a little bit like a game of hot potato. So I missed the first meeting. That's how I became president. The next president, Peter Karillas, at his age, he does not move very quickly. Hence, he became the second president of the AFS. It's a 2-year term. We alternate between surgeons and GIs. Peter needs really no introduction, obviously. His contributions to foregut are ginormous, if that's a word, in the foregut space and specifically in motility. I can tell you I didn't know Peter very well until we formed the AFS, and I can tell you it's an example of dogs and cats living together, but actually becoming dear friends. Peter is a tremendous person, and consider him a very good friend. Like I said, he's into his first year as president, and I'd like to bring him up stage at this point, and he will tell you all about the society. You move really fast.
Thanks, John. Well, this is really fun to be able to give this talk. I was given my domain, a free domain of what I wanted to talk about. So I thought I'd tell you a story. And it's a story that I think intertwines with the core principles of AFS. It's the story of Flip. So these are my disclosures. I have to throw them out there. One of them is, of course, Flip, where John Pandolfino yesterday announced that he got $750 for every device sold. I'm not sure I do that well. Oh, 75? Oh, he's been downgraded. Okay. Probably that's what I get. I know it wasn't 750 anyway. So, mentorship. So in the beginning, what was there? Well, John and I started together when he was a fellow. And so he was my research fellow, clearly the best I've ever had. And we were investigating this idea of distensibility, and we together developed this device called the hydrostat. So this was published in 2003, and it's a simple device. What we were looking for was a way to distend the EG junction. So we modified a barostat, and you put air into that chamber. That chamber exchanges the air for some rhenographin. The rhenographin distends the balloon, which is straddling, or bag more accurately, which is straddling the EG junction, and it registers a pressure. So if you combine that data with fluoroscopic data, shown here, taken at the same time, you get the pressure and the distensibility of the EG junction. And we wrote a rather nice paper about that, showing how this actually figures into the pathogenesis of reflux disease, because the worse the disease, the more distensible the sphincter, or the EG junction more accurately, seemed to be. Well, John presented that paper at DDW, and another core principle here, collaboration. So a member of the audience, who's here today actually, John O'Day, had a little company, or was about to start a little company. And he said, you know, I can make something that does this without X-ray. So some years later, this device emerged, the functional luminal imaging probe, really designed to do a similar thing. You put fluid into it. It's a conducting fluid. You use impedance plethysmography to measure the distensibility at each electrode location, and you get a pressure sensor in there, so you have the same kind of data, although you're not using fluoroscopy and a barostat and all the rest of it. Now you have an electronic device that does this, and of course there's some other subtle differences as well. Well, one of the first things we looked at with this was achalasia. And looking at EGJ distensibility as a criterion for achalasia, this was one of the early papers. And here you see we've brought on Dustin Carlson as the first author for that paper. And Dustin is the prime mentee of John. So we do have a legacy at Northwestern. So what he showed here was the achalasics, type 1, 2, and 3, all had low distensibility. EGJ outflow obstruction, not surprisingly, some were normal, some were abnormal. The jackhammers were abnormal in this series. There were only 3 of them, and the others looked like they were above the line. So that was kind of the first indication, or the first application, I should say, of FLIP in the clinical domain. It was in achalasia diagnosis and subtyping, and potentially to be used in lieu of manometry. Because in some instances, and this has only been reinforced as time has passed, the result is so obvious you really don't need to go forward. Admittedly, there's lots of overlap, and a lot of what we focus on is the overlap, but nonetheless, there are very clear-cut cases. And this would be the type of portrayal you would get of the EG junction in an untreated achalasia there on the left, where you have an hourglass. On the right, you're looking at good response and poor response. The good response, it's opening. The poor response looks like the untreated. And that was a key observation as well, because what became apparent, and this just summarizes those data, is that this was a better assessment of treatment outcome in achalasia, meaning physiological treatment outcome, than was manometry. So for achalasia, you had both the detection and also the assessment of treatment response. You can also use it intraoperatively as you're doing the treatment. So in the course of doing a myotomy or in the course of doing a per-oral endoscopic myotomy. And that's where it stood for a while, and then they made the device longer because we started getting interested in the esophagus, first in the domain of eosinophilic esophagitis to see if there was a way of quantifying the fibrosis of the esophageal wall. But that actually advanced, and we would get tracings like this. Now, at the time, we were looking at just the distensibility, so we saw all these squiggles here. We're kind of noise, and we were working with an engineer. Another core principle of the AFS, I think, is collaboration. And one of our key collaborations has always been with mechanical engineering at Northwestern. So our engineer at first was trying to filter out these squiggles until, Dr. Pandolfino was looking at this once, and it occurred to him that, those squiggles might mean something, because this is a dynamic representation of esophageal diameter. So it's not pressure, it's diameter. So if you look at these, it's kind of looking at high-resolution manometry. And what did you do with high-resolution manometry? Well, you transformed it into topography. So the squiggles became flip panometry. And now you're looking at esophageal diameter topography. So although these look like pressure waves to all of you, because that's what you're used to looking at, in fact, they're not. These can be lumen-occluding or non-lumen-occluding, but these are contractile waves because you're looking at diameter topography. That was a great example of innovation as well as collaboration, because from there, we put Dustin to work for the next 15 years or so. I mean, because now he's got to figure out how to make sense out of what we've got here. So let's look at what you can learn from diameter topography. Well, looking at this, one would be the functional assessment of EGJ outflow obstruction, a key thing to quantify as one is looking at motility disorders. This is a paper, you're losing the reference on the bottom there, but it's actually in press in CGH, where Dustin has now put together a series of about 700 patients. They've all been studied with HRM, so we know what the HRM assessment of them is, and a lot of them have outflow obstruction, and there are 35 controls in there as well. And the flip data were all exported and analyzed with open source software. And that's the website for accessing that. This is written by Walter Kuh, who is now on our faculty as a research faculty member. Again, he was through the McCormick School of Engineering at Northwestern. And two metrics are looked at here in assessing the obstruction. The distensibility index, which you've heard about elsewhere in this meeting, and the maximum diameter of the EGJ, excluding areas where there's a dry catheter artifact, which I won't bother describing right now, but it's something that you should be aware of. Now, when you look at this, and you're looking at the measurement of the EGJ-DI, it's all over the place. So what you've got to do is find the right places to look. And that's looking at this, the apex of the EGJ-DI. So you get in between the contractions so that you can see where the diameter of the EGJ is maximal. Now, as I was looking at some of the surgical presentations earlier, I'm wondering how you do this intraoperatively. Presumably you go to areas where there's no contractility. But when there is contractility and you're getting these repetitive antegrade contractions like this, you've got to sneak your measurements in between the contractions, because what you're interested in is what it can do, not what it's necessarily doing at any particular moment. You also want to find the area of maximal diameter, and that can be anywhere in the tracing of 60 or 70 mLs, and there that's picked out, it's 21 millimeters. So those are the two metrics that have been isolated as indicative of outflow obstruction. Now in controls, those are the values that have been derived. They've been evolving a little bit as we've gotten larger experience. But the median for the maximum diameter is about 20, and for the DI is about 5.8. This is somebody who has achalasia. And here it's the DI is 1.3, it's not marginal. And the maximum diameter is 10, it's not marginal either. That's why I say sometimes you look at a flip tracing and you really don't have to go any further. It's pretty obvious that this is an achalasic. We talked a bit about difficult discriminations between diagnoses. Well, strangely enough, a difficult distinction to make can be between scleroderma and type 1 achalasia, because there's no contractility in the esophageal body, and there's some degree of outflow obstruction. Well, this is an interesting case because this was one that kind of looked like it was type 1 achalasia manometrically, but in terms of the flip study of outflow obstruction, the EGJ-DI was 10, which is way above the median for normals there, and the maximum diameter was 21, so this was clearly a normal distensibility here, and very useful in evaluating one of these gray zone cases. So past those two examples, let's look at the entire data set. And here you're looking at the 400 or so patients that I mentioned. You got the controls up there on the right. You got all of the achalasics in the red triangles. And if you apply those two metrics, and we downgraded the EGJ-DI to a value of 2, and the diameter downgraded to 16, and those two in combination completely isolate the controls from the achalasics. So yes, you can measure outflow obstruction with this device using those metrics. But we went a little further there because, again, one of the other principles I think that has been brought up at this meeting repeatedly is the fallacy of dichotomous cutoffs. They're nice conceptually, but they don't work in the real world where everything is a continuum. So in strategizing this, these are the outcomes with respect to EGJ outflow obstruction. Either normal, in which case the DI is greater than 2 and the maximal diameter is greater than 16. Reduced, in which case it's less than 2 and less than 12, or borderline, where you meet one and not the other. So there is a gray zone, and I think appreciation of the gray zone is important. I think what Mike Vasey showed earlier was very elegant in that think what you might of the impedance data itself, the analysis process, I think, is ingenious. That what you have to do is think of the measurements you're making in terms of the probability that they're telling you an outcome of interest. So these are the patients within that subset who had EGJ outflow disorder of EGJ outflow on HRM, and how they played out with a flip assessment. You'll notice that most of them are in that red rectangle down there. And of equal interest, you'll notice the two sclerodermas who went into the normal there. So there were two patients who had scleroderma who were read as being outflow obstruction on HRM, who were clearly clarified by the flip study. Now these are the ones who had normal EGJ outflow on HRM, and the 35 controls thrown in there, and you can see that most of them migrate toward the green, although admittedly there's a cluster in the yellow and some in the red. So based on that analysis, let's make a couple of summary statements. One, among the 241 patients with reduced outflow, 86% had a conclusive HRM diagnosis of EGJ outflow. And among the 203 patients who were normal, 99% had normal EGJ outflow per CC 4.0. So a normal study was very helpful, and you could even say that it obviated the need for HRM. Well, we've gone a little further here, and now we're looking at the functional assessment of secondary peristalsis. And this is going to be all new to the uninitiated, but it's basically the same methodology. We've got a little bigger group of people. We're using the same open source software. We're looking at the larger volumes on the FLIP study because these are the ones where you're likely to see some induced secondary contractility. And the contractile response patterns have been categorized as follows: normal, borderline, impaired, disordered, or spastic reactive. I'll show you what these things look like. These studies were read blinded because they wanted to show the applicability of this technology. So these are racks. These are repetitive antegrade contractions. This is the normal contractile response. And there's the rule of sixes introduced there, that the rate should be 6 plus or minus 3. They should go 6 centimeters in axial length, and there should be at least 6 of them. This is borderline. Now, with borderline, you don't see the repetitive antegrade contractions, but you see some antegrade contractions, and it doesn't meet the rule of sixes. This is impaired, disordered. So there's some contractility going on, but not meeting any rule for borderline or for repetitive antegrade contractions. But there clearly are contractions in there. Some look like they're going forward, some look like they're going backward. This is absent. So throughout the distension through the 50, 60, and 70 ml, you're not seeing any contractility in the esophageal body. And then spastic reactive. So with spastic reactive, this is the first pattern that was described, the repetitive retrograde contractions. And as these have been analyzed more and more, yes, they're 6 centimeters in axial length. The frequency is different. So they're greater than 9 contractions per minute. And this example had type 3 achalasia on HRM, but that's a distinctly abnormal thing. Another spastic reactive pattern is this. It's a spontaneous lower esophageal sphincter contraction. So here, what you're seeing is that as you distend this, the LES is actually contracting for greater than 5 seconds, independent of esophageal body contractions. So this example had hypercontractility and a small hiatal hernia on HRM. This was seen in 7% of the patients overall. 32% of them had an epiphrenic tic, or 32% with an epiphrenic tic had either this or an SOC, which I'm going to show you next. And hiatal hernia was more frequent with these. This is a spastic reactive contractile response described as an SOC, or a sustained occluding contraction. We all have seen these, or we've all experienced these when we've done pneumatic dilation. It's like you caught a fish, basically. You're holding on to the dilator, and all of a sudden, it is pulling you into the person's esophagus. This is what's happening when that happens, and it's a very profound contractile response. So how does all this compare to high-resolution manometry? Well, that's a difficult thing, because you're looking at 2 different things. You're looking at primary peristalsis and then reactive contractions. So this was the first pass analysis on this. If you look at the ones who had NCR, normal contractile response, and what their corresponding HRM patterns were, you'll see most of them were normal. So on the average, 80+% of their swallows were normal on HRM. If you look at the borderline, that dwindles a little bit, and you get a smidgen of the rest, but it's borderline. If you look at the IDCRs, now you're starting to see patterns of failed contraction emerge a lot more and a lot less normal. If you look at the absence, not surprisingly, they're showing absent contractility on HRM as well. And if you look at the spastic reactives here, you start seeing a lot of pathology and not so much in terms of normal. So there is a rough parallel between the two, but a very good parallel in terms of the normal. Now, teasing them apart and putting it all together into both the normal contractile response here as well as the outflow assessment, how did that all pan out? Well, the normal contractile response, by and large, had normal outflow metrics as well, some into the borderline there, but basically they were normal. If you look at the borderlines, there's still a lot in the normal, but now there's more in the borderline and some in the reduced EGJ outflow. If you look at the IDCRs, the impaired disordered, they're slipping into the reduced. So this is a pattern that you're seeing in conjunction with reduced EGJ outflow. If you look at the absent, it's getting very red down there because this is clearly identifying type 1 achalasics. And if you look at the spastic reactive, again, they're mainly abnormal. There are a few there that are normal, but most of them are down in the borderline or in the reduced. So how can we summarize this? Where is this going? Well, you're seeing a transition from normality, which is NCR with RACs, to abnormality, which is BCR or ACR, paralleling primary peristaltic function as assessed by HRM. There's some discordance, but a couple of reasons for that. Panometry detects non-occluding contractions. Abnormal spastic motor contractions, meaning IDCR or RCR, are observed. SOCs end up being better than RRCs to differentiate type 3 achalasia from non-spastic achalasia. RRCs, SOCs, and LESCs are observed in patients with spastic motor findings on HRM, hiatus hernia, and epiphrenic tic, suggesting that when these are seen, they merit further clinical evaluation. Most importantly, these are complementary evaluations of esophageal function. They're never going to exactly parallel it, but they do tell you some very useful things. And a normal contractile response on flip panometry in the setting of a normal endoscopy effectively rules out achalasia, which is arguably the most important diagnosis you need to make. So, conclusions. Very importantly, this test is easily done in conjunction with sedated endoscopy. All of the data that I've shown you was obtained during sedated endoscopy, so no hassles about catheter placement. It was equal to or better than HRM in detecting achalasia. It's an effective measurement of treatment efficacy in achalasia. It provides a better assessment of EGJ outflow irrespective of the IRP, or it provides a functional assessment irrespective of IRP. It has the potential to replace HRM in the detection of esophageal motor disorders. And I think that's where this story is right now. It is an unfinished story, but I think that it illustrates, and this played out all in all over 20 years, several principles of the AFS, which I'd just like to highlight. Mentorship. You have seen 2 generations of mentorship play out here, and it's not finished. Partnership. Partnership with industry. Told you the story of Crossbond. Innovation. Key at several steps along that pathway were innovation. Collaboration. In the course of these studies, we've, of course, The core has been GI, surgery has been involved, clinical psychology has been involved, industry has been involved, mechanical engineering has been involved. And as a result, I think it's a good example of the development and implementation of a very impactful technology. Thank you.
That was great, Peter. Well, that was fantastic, Peter. In fact, in many ways, I think the crowd probably would agree you deserve a cut of the $75 that John gets. Some other benefits of the presidential address is you get to pick your own topic, you get the $75, and more importantly, you don't have to answer any questions. So what we're going to do now is we're going to break for lunch. There is lunch being offered in 3 different lunch and learns. They are all going to be in the Bayou rooms, which if you walk out there and go that away, you should be able to find them. There will hopefully be a little bit of signage there. The 3 different lunch and learns, you don't have to have previously registered or anything, just show up, are CDX, Fathom Pharmaceuticals, and Gore. We will then meet back here at 1 o'clock to do the afternoon session. So enjoy lunch, and we'll see you after the break.
Where are they?
The Bayou room.